Dr. Doug Bradley, who has already sort of been introduced earlier today. Dr. Bradley is a respirologist who was appointed the Clifford Nordell Chair in Sleep Apnea and Rehabilitation Research in 2013. He is the Director of Sleep Research of the Sleep Research Laboratories at Toronto Rehab and Toronto General Hospital. He is the Director of the Division of Respirology and the Centre for Sleep Medicine and Circadian Biology at the University of Toronto. His clinical and research work focuses on the causes and consequences of sleep apnea on cardiovascular diseases, especially heart failure, hypertension, and stroke. Together with his colleagues at Toronto Rehab's Research Institute, he invented Brezzo DX, a game changer in the diagnosis of sleep apnea. They were honored, this team was honored as UHN Inventors of the Year in 2015. Brezzo DX, and I know Doug's going to talk about it more, but it provides a reliable assessment of sleep apnea at home with minimal inconvenience at a cost that is much less, significantly less, than at a sleep lab. I'm delighted to announce that in May of this year, the Ministry of Health and Long-Term Care announced that this breakthrough medical device developed by Doug and colleagues right here at Toronto Rehab will be available to Ontario patients through select clinics throughout the province of Ontario. Doug.
Well, thank you very much for your kind introduction, Cindy, and it's a pleasure to be here this morning, and thank you all for coming. I want to start off first by expressing my gratitude to those who made significant contributions to the chair which I hold, the Clifford Nordell in Sleep Apnea and Rehabilitation Research. First of all, of course, Cliff Nordell, who's sitting here, and Paul Weiss, who headed the committee that helped raise the funds for it, and of course, Cindy Yell, the director of the foundation. So I hope that you will feel after I've given my talk that your faith in me was well placed. Okay, so what I'm going to talk to you about today is sleep apnea, its impact on heart health, and innovations in diagnosis and treatment. Well, first of all, let's just talk about what sleep apnea is. So this is an illustration of a man lying on his back. We're looking at him from the side, and he's awake here. And this is the nose, this is the mouth, here's the tongue, and here's the airway, or the pharynx. You can see that the airway is open, and that's inside this circle here, so he can breathe. When he goes to sleep, the muscles of the tongue relax, and in somebody with a big tongue or a small jaw, the tongue will lose tone and fall back against the airway, and compared to here, you can see the airway is blocked. So it's basically a cork in the throat. They struggle to breathe for a period of 10 seconds or more until the lack of oxygen finally wakes them up. So an apnea is a complete obstruction of the upper airway. A hypopnea is a partial obstruction where the airway is slightly open but not enough to provide adequate ventilation. And the duration of these episodes is from 10 to 120 seconds, and they can be as frequent as 5 to 120 per hour. So if you have more than 10 or 15 per hour sleep, you have what's called a sleep apnea disorder. Now, talking about following on Jan's talk regarding sympathetic nervous system activity, this is just an illustration with direct measurement of sympathetic activity from the perineal nerve in the leg. And this is a normal subject, and each one of these little spikes here represents a burst of sympathetic nervous system activity, and this shows blood pressure. So when you're awake, you have these bursts, and when you go into light sleep, they diminish. When you go into deep sleep, they diminish further, and that's in conjunction with a fall in blood pressure. So as the sympathetic activity falls from wakefulness to sleep into deeper sleep, your blood pressure goes down, because sympathetic activity also controls blood pressure as well as alert state. Finally, here in the deepest state of sleep, it's almost gone. However, in rapid eye movement sleep, when your brain is very active and you're thinking and dreaming, the sympathetic activity actually goes up, as does blood pressure. So in some respects, REM sleep is a little bit like wakefulness. Now let's go to a patient with sleep apnea and show you the difference. So this patient has an apnea. So the apnea is shown here. The breathing is not normal. This is normal breathing here. This is an apnea. And this is a sympathetic nerve burst frequency shown here. And as you can see at the beginning of the apnea, it's low, and then it rises and rises and rises. And the reason it rises is because the lack of oxygen stimulates the sympathetic nervous system. And the reason it does that is because, of course, you need to wake up in order to get rid of the obstruction of your airway. And the sympathetic nervous system, as Jan pointed out, is fundamental to alertness. So at this point here, the sympathetic activity has become so high that the patient wakes up and you can see that the blood pressure is falling and then starting to go up. And when you wake up and have a sudden burst in sympathetic activity, your blood pressure reaches a peak and then goes back down. So as I showed you before, ordinarily your blood pressure will go down during sleep, but when you have obstructive sleep apnea, it does exactly the opposite. It goes up. So at a time when the heart should be put at rest with a low blood pressure, it's actually running a marathon. Now, what can be done about that? Well, this is another recording from a patient with sleep apnea. This is the sympathetic activity while awake. It's very high. This is the blood pressure, which is actually within normal limits. A patient goes to sleep and has the obstructive apneas. They stop breathing. The sympathetic activity goes way up compared to even wakefulness. The blood pressure goes up, and once they wake up, the blood pressure goes down, the sympathetic activity goes down, and then they have another apnea, goes back up again. So what can you do about that? Well, if you treat this patient with CPAP, continuous positive airway pressure, inflate the airway, prevent the apneas, this is what happens. You go from this level of sympathetic activity to this level, and you go from this very high blood pressure, which hits 250 millimeters of mercury, to back to normal. So treating obstructive sleep apnea reduces sympathetic activity, and as Jan pointed out, interruptions of sleep by excessive sympathetic activity is one of the things that leads to daytime sleepiness because you get a poor night's sleep. So by treating the sleep apnea, you get rid of these surges of sympathetic activity, you allow the autonomic nervous system to settle down, and you get a better night's sleep. Now what are the implications for cardiovascular disease? Well, this is a study we published back in 2003, and we looked at patients with a combination of heart failure and obstructive sleep apnea, and we did a randomized trial on 24 of them. 12 of them got CPAP, 12 of them didn't. We followed them up for an hour, and for a month, and we looked at what happened to their blood pressure. So here's their heart rate and a control group from baseline to 1 month later, no change. Systolic blood pressure, no change. Diastolic blood pressure, no change. In contrast, in those who were treated with CPAP, the heart rate came down, the systolic blood pressure dropped by 10 millimeters of mercury, the diastolic blood pressure didn't change. The point is that by reducing sympathetic activity at night, we actually reduce sympathetic activity in the daytime, and the result is a lower heart rate and blood pressure, which is exactly what you want when you have heart failure. And this is an illustration of what happens to the sympathetic nervous system. So on this plot, this axis here, we have the number of nerve bursts from the sympathetic nervous system. The higher, the more activity there is. This is the control group who didn't receive any treatment, and we can see that there's no change. The mean level has not changed over this 1 month period, and this is measured during wakefulness. In contrast, this is the group who was treated with CPAP, and we can see that in every case, the sympathetic nerve burst frequency fell. So they're becoming calmer, more relaxed, and their blood pressure is dropping. So in conclusion, in medically treated heart failure patients with OSA, obstructive sleep apnea, CPAP reduces systolic blood pressure and lowers heart rate due to reduced sympathetic nervous system activity. Now, we know that excessive sympathetic activity is related to mortality in heart failure. The higher the sympathetic activity, the greater the mortality rate. And the most powerful treatments for heart failure ever developed are beta blockers. And beta blockers reduce sympathetic activity in the heart. And they are the most powerful drugs for heart failure. So, this is a plot of mortality, survival rather, shown here in this axis, and this is time from when patients with heart failure had a sleep study. And we divided these patients with heart failure into 3 groups. A group in red who does not have sleep apnea, and you can see that over this period of up to 7 years, there were 14 deaths, or 12% of them died. The blue plot is a group of patients with heart failure who had obstructive sleep apnea, and their mortality rate is twice as high, 24%, and the difference between these 2 groups is highly significant. So there's a higher mortality associated with untreated obstructive apnea in patients with heart failure. The black line here represents patients who had sleep apnea, who were treated for the sleep apnea, and you can see over this period of time, none of them died. The difference between these 2 groups, the treated and untreated, is not quite significant, but it's verging on it. So the implications for this are that untreated sleep apnea is a risk factor for death in patients with heart failure, and that possibly by treating it, you might be able to reduce mortality. However, this was not a randomized trial, it was just an observational study, and we know that observational studies are often confounded by factors that we can't control for. So the way to look at this is with a randomized trial. So we developed a randomized trial that's called the Advent-HF trial, and I am the principal investigator of this trial, and it's sponsored by the University Health Network and Toronto Rehab. It stands for Adaptive Cerebral Ventilation for the Treatment of Obstructive and Central Sleep Apnea and Heart Failure, and is jointly funded by the Canadian Institutes of Health Research and an unrestricted grant from Philips Respironics, who makes this device. Basically, we take patients with heart failure, we do a sleep study on them. If they have sleep apnea, they get randomized to this device called adaptive cerebral ventilation, which is a fancy form of positive airway pressure, or CPAP. And we divide them into those who get the treatment and those who don't, and then we follow them up for up to 5 years. And the main endpoint is the composite of deaths from all causes and hospitalizations for cardiovascular disease. Now, this is a huge trial. It's multinational. We're in 9 countries now. This is the country: Canada, United States, Germany, Italy, Spain, United Kingdom, Brazil, France, and Japan. And we have a total of 42 centers at the moment. And at this time, we've enrolled 462 patients out of the 860 that we expect. So this is truly an international trial, and it's centered here at Toronto Rehab, and it's part of what's come out of the Clifford Nordell Chair. Now, so the results of that trial should be known in about 2 years' time, and if we show that we reduce mortality, it will be basically revolutionary in the treatment of heart failure. We'll see. Now I want to shift to some more basic physiological research to look at what causes sleep apnea. So I can't go into the details of why we developed this hypothesis, but this is a hypothesis we developed about 10 years ago, and it's called overnight headward fluid shift. So during the daytime, when you're upright, liquid is retained in the legs, like the fluid in the bottom of this bottle. Okay? If you're sitting particularly, you will collect fluid in your legs. And like this bottle, when you tilt, you lie down at night, this fluid flattens out. In this case, the fluid can go into the lungs or into the neck. So when recumbent while sleeping, fluid retained in the legs moves to the upper body. If fluid accumulates in the neck, it may narrow the throat, predisposing to its collapse and to OSA because it creates pressure around the throat. If fluid accumulates in the lungs and stimulates sensors, it may cause hyperventilation and reduce carbon dioxide levels below the threshold for apnea. And I know you may not quite understand that, but I don't have time to explain it in detail. So this is these are 57 patients with heart failure who retain fluid. It's part of the syndrome. And this axis shows the amount of fluid that moves out of the legs at night and upwards into the upper body. And this shows the frequency of apneas per hour of sleep here. So the higher the level, the worse the sleep apnea. And this red line represents obstructive sleep apnea, and we can see that as more fluid moves out of the legs, we get more and more sleep apnea, worse and worse. And the yellow line represents central sleep apnea, and it shows that they have more fluid coming out of the legs in the OSAs, but the relationship is the same. The more fluid that comes out of the legs and goes to the upper body, the more severe the sleep apnea. So this is what we've developed then. During the daytime, if you're inactive and sitting a lot, you get dependent fluid accumulation in the legs. And at nighttime, when you lie down, you get rostral, which means headward shift of the fluid from the legs up to the neck and chest. Depending on where it goes, either in the neck or the lungs, you can end up getting obstructive or central sleep apnea. So this is a brand new hypothesis, and I'll show you the evidence that it's true. So the background here is a randomized trial that we did actually at the Cardiac Rehab Center at Rumsey Road. And sleep apnea increases the risk for death in patients with coronary artery disease. And exercise cardiac rehabilitation is associated with a 50% reduction in death rates. And that was work that comes out of Rumsey Road. The cause of this effect has not been determined. One potential mechanism for this effect may be attenuation of sleep apnea. So here we have the calf muscles, here, and this is the blood vessel in the leg, the vein. It has one-way valves that only allow fluid to move upwards. If you're just sitting there, the pressure in this thing will cause fluid to leak outside of the veins into the leg itself. But if you contract your muscles, it squeezes these veins and forces the blood upwards. In other words, walking prevents fluid retention, sitting causes it. So leg fluid volume will increase by 100 to 300 milliliters in each leg if you're sitting for long periods of time. So we developed a trial where we took patients who had coronary artery disease and were sent to Rumsey Road for cardiac rehab, and we randomized them to a group who did not get cardiac rehab and a group who did for a period of 1 month. And the rehab is mainly walking or cycle or on a stationary cycle. And what this shows is the amount of fluid in the legs at the end of the day. And we can see that in this group who was exercising, that fell significantly over a 1 month period. In contrast, the group who did not exercise had no change. Similarly, the overnight movement of fluid out of the legs was reduced by the exercise treatment, as shown here. It went down from this amount to this amount. In contrast, in the control group, it did not change. And then we looked at the size of the upper airway, because the upper airway is where the action is in sleep apnea. The larger the upper airway, the less likely you are to have sleep apnea, and vice versa. So if we look at the size of the upper airway in the morning after they've slept, it's changed from baseline to 1 month later in the exercise group, it's increased in size. In contrast, in the control group, it's actually decreased in size, and the difference between the two groups is significant. In other words, and also the overnight change. So here, the airway is getting larger overnight, and here it's getting smaller overnight. So what that means is the movement of fluid, the reduction in the movement of fluid into the neck due to exercise is causing the airway to get bigger and therefore preventing sleep apnea, which is shown here. So here we have the control group from baseline to 1 month later where they were not exercising. There's absolutely no change in the severity of sleep apnea. It's quite severe. The average apnea index is about 30 per hour. In contrast, in the exercise group, the apnea-hypopnea index has dropped very significantly in almost all patients. And so in conclusion, in patients with coronary artery disease and obstructive apnea, exercise over 1 month reduced the total AHI by 36%. This reduction was related to a reduction in the overnight shift in leg fluid volume and an overnight increase in upper airway cross-section area. Therefore, reductions in overnight fluid shift and increases in upper airway size are mechanisms by which exercise reduces the apnea index in patients. And reduction in the severity of OSA may be one of the ways by which exercise reduces death rates in patients with coronary disease. So this is a new invention. It's called the walk station, and many of us are very sedentary, and this may be the solution. So here you can multitask. You can walk on your treadmill, lean on your desk, work on your computer, and use the telephone all at the same time. But many of us don't like to exercise, but here's the alternative. What fits your busy schedule, sir? Exercising 1 hour a day or being dead 24 hours a day? Take your choice. Okay, so now I want to move on to our invention. And our invention came up because of an unmet need. Obstructive sleep apnea affects 10% of the adult population and is very common. But due to inaccessibility to polysomnography or sleep testing, and home sleep testing, and the high cost of testing, about 85% of those with obstructive apnea go undiagnosed in North America. Consequently, there's a very large unmet demand for sleep apnea testing. So, our solution was a disruptive technology, a game changer for sleep apnea diagnosis, which we call BreezoDX, which stands for Breath Sounds Diagnosis. And this is a picture of what it looks like. It's basically worn over the head. And we've tested this device, which measures sound as you're breathing during the night, and we can tell when you stop breathing. And we tested this against the gold standard polysomnogram in a sleep laboratory simultaneously, and we found that the apnea index detected by our device versus the sleep test is exactly the same, as shown here. They're almost identical, which means that just by measuring breath sounds with a battery-operated device in your own home, you can make a diagnosis of sleep apnea as accurately as you can with a sleep study at a much lower price and much greater convenience to the patient. As pointed out by Jan, sleeping in the sleep laboratory is not necessarily your normal night's sleep, but if you take this device home and use it in your own home, it is. So, as Cindy pointed out, there will be implementation of BreezoDX in Ontario. It was the first newly developed device to undergo independent testing by the Excite program in Ontario, and they recommended that it be adopted by the healthcare system. So May 16th, the Ministry of Health announced that it would be instituting a demonstration project in 10 to 25 sleep clinics across Ontario, in which BreezoDX could be used to diagnose sleep apnea. A fee would be provided to the sleep clinics for the use of BreezoDX, and the Assistive Devices Program will provide CPAP to treat sleep apnea on the basis of a diagnosis made by BreezoDX. This is basically revolutionary in the Ontario healthcare system. Something like this has really never been done before. And just to show you that our device has not been unrecognized, as Cindy pointed out, Hisham Elshar, Jeff Fernie, and myself received the UHN Inventor of the Year Award for this development. We also won what's called the Redefining Early Stage Investments and basically biotech startups. We won that competition at Mars Health Kick Innovations last year. We also received the Product of Outstanding Interest Award from the European Respiratory Society in 2016. So, although I think we've accomplished much, there are many more challenges on the road ahead, and I hope with your help and support, we'll get there one step at a time. Thank you very much for your attention. I think we'll